morning, everybody. We are having a knowledge sharing platform here on this day. We have eminent personalities from WHO, Thailand, and HITAP. So I welcome all the participants in this meeting, and Ratan sir, over to you for the opening remark.
Thank you, Latif, and good morning or good afternoon from whichever time zone we have joined this get together. It's indeed a pleasure that we are having this kind of an interaction with the stakeholders from Thailand. It is a pleasure to know that a lot of work has already happened in Thailand, and we in Kerala as well. Looking at the way in which we've been handling the program of dialysis, we are probably the pioneers in the country in terms of starting the peritoneal dialysis and ensuring that the services are given to the people in the most affordable manner and in the most equitable manner. The government of India also has been now examining the possibilities of looking at other options for dialysis, like the peritoneal dialysis itself. And Kerala, through its pilot approach, we have shown to the country that peritoneal dialysis is not only affordable but also very convenient for the people as part of the management of the issues people are facing. And in this background, it is heartening to note that a lot of good work has already happened in Thailand, and we are fortunate to have this kind of a discussion today so that we will learn the best practices which is happening, and also based on the guidance which comes out of this workshop or meeting, we will be able to fine-tune our approach as well going forward. So with that in mind, we're extremely happy that we've been able to come together for this kind of a meeting, and extremely glad and also thankful for WHO for making this happen. And this outcome definitely would help the state in moving forward in the right direction with more vigor than what we've been doing earlier. My team has also been very active in this entire scheme of things, right from the pilot onwards to roll out across the state of Kerala. The National Health Mission team of the Department of Health and Family Welfare, the state of Kerala, has been very actively pursuing the best practices in this entire scheme of things. So without much ado, I think I will now hand it back to Latif to take it forward. We hope that we'll have a very good deliberation and learn from the implementation in Thailand, and probably we can also give some feedback which could be of use to those implementing back in Thailand as well. So with that, I stop here and wish this deliberation the very best, and I hope that we will learn from each other and move forward in the interest of effective healthcare delivery for our people. Thank you.
Thank you, sir, for your opening remark. I welcome Grace Cabania for setting up the platform and an introduction. Over to you, Cabania.
Good morning, everybody. Good morning once again. Thank you, Dr. Kelka, and I'd like to also welcome the Thailand team. I want to say thank you, first of all, to Dr. Kelka for immediately welcoming the request or suggestion that we made when we were reviewing the State Health Authority and the strategic purchasing. We came at it from the understanding that Kerala has taken very giant steps in terms of optimizing the health insurance for the publicly subsidized health insurance in Kerala by converging the schemes and broadening coverage. But we were seeing costs escalating, and a key issue there is how do we manage to contain costs while ensuring that we maintain service coverage and the financial protection therein. And that is where there was a meeting of the minds in inviting Thailand on board to share their experience, because in a way they have been a front runner in this regard. And it's not so much that Kerala should do this. I think it's more about the how, in order to make sure that what Kerala has started can be made better in order to bring minimal savings, make it more efficient. And like you've said, Dr. Kelka, that both sides can learn from each other's experience in terms of the political economy, but also the technical of how to do, to go about ensuring dialysis for all that they need. So for us at WHO, we are very happy to be part of this exchange. We look forward to learning more from both sides, but also we hope to see something grow out of this that is mutually beneficial for both Thailand and for Kerala, but also hopefully on a much broader scale for India. Thank you very much.
Thank you. And with regard to familiarize Kerala's experience in managing dialysis case, I would like to invite Dr. Bipin Gopal, SNO. Sir, over to you. I think you will share the screen from your end.
Yeah, thank you. I'll share. Are the slides visible?
Yes, sir, but it is not in the slide share mode.
Is it moving?
No, sir. Could you please make it in the slide share mode?
Yeah, it's in the slide share mode.
Sir, ഒന്ന് വലുതാക്കിട്ടെ നമ്മളെ slide ആക്കിയാണ്.
അല്ല ഞാൻ slide share ലായിട്ടിരിക്കുന്നു.
Yes, sir. Please click there. Then it will be slide share mode.
Is it okay?
Yes, sir. Please go ahead.
Okay. So good morning, all. Dr. Rathan Kelkar sir, Dr. Grace Kambania, Dr. Somsak, Dr. Bijoy, Ms. Latif, and all dignitaries present for the meeting. I'm Dr. Bipin Gopal. I'm looking after the non-communicable disease control program in Kerala. This is regarding the CAPD implementation in Kerala. As we look at the state, are my slides moving now?
No, sir.
It's moving. Okay.
It's not moving.
Not moving. So can you do one thing? Can you share it from your side?
Yes, sir. Yes, sir. Definitely.
I'll stop share here. Okay, next slide. So this is the profile of Kerala state. We have a population of 33.39 million with a men population less than the female population, which is intended. And we have a high population density of 859, one of the highest in India. We have a high literacy rate of 93%, one of the highest in India, even though it is declared as 100% literacy. Everybody can read and write. We have a low IMR, infant mortality rate of 8, and a low MMR, maternal mortality rate of 42, which is also one of the best in India, the lowest in India. And we have a highest life expectancy in India of 75.4 years. Even though this is a rosy picture, on the next slide, on the non-communicable disease slide, next slide, no, previous one. We are on the highest epidemiological transition zone, and that has resulted in the rampant urbanization, and the lifestyles of people have changed rapidly. So as a result of that, we have a high prevalence of hypertension, we have a high prevalence of obesity, we have a high prevalence of diabetes, and this has led to the increased number of CAD cases, the increased number of stroke, especially the young strokes in Kerala. The cancer density of Kerala is highest than that of India. We have a high COPD cases in Kerala, and the renal diseases we should say that it is one of the highest in Kerala. Even in the health service department itself, we have got 88 dialysis centers, and some of the dialysis centers are functional even in the primary health centers and the community health centers. So that is the burden, that is the density of end-stage renal diseases that is happening in Kerala. So next slide. And if you look at the end-stage renal disease, globally also there is a rise. If you look into the different countries, the end-stage renal diseases are going up every year. And if you look at the survival of the dialysis patient, it is similar or even worse than most of the cancers. So if you look at the green line, you can see that the survival rate of the dialysis patient is coming down very quickly, and it is more worse than some of the cancers. So next slide. And even though the peritoneal dialysis is proven as an alternative of the hemodialysis, the use of peritoneal dialysis is not that rampant anywhere in the globe. Even in India, even in the states of India, the peritoneal dialysis program has not got that much importance. If you look at any country, that the hemodialysis cases are more. Next slide. So what are the challenges that we do have in hemodialysis? We need a direct venous access. There is the high use of central venous catheters, which can lead to infections. The cost and infrastructure in setting up a hemodialysis unit is much more. The staff requirement is much more. Then the cost of machines, dialysis equipment, the transportation cost is much high. And the treatment-related complications are also very high in hemodialysis. The inconvenience and the lack of flexibility, because the patient has to come to the hospital every time for dialysis. He has less freedom to travel away from the dialysis centers. So these are the inconveniences that we do have in the hemodialysis cases. Next slide. But even though peritoneal dialysis is as good as hemodialysis, there are a lot of advantages for it is favorable for the home-based treatment. It can be done by a single person. It provides the patient flexibility and convenience. There are advantages in short-term outcomes, and the cost factor, if you look into the cost factor also, the cost factor is very less or more or less equal to hemodialysis. So the advantages of the peritoneal dialysis is much over hemodialysis, but it has not taken off well in India. Next slide. So we look into the Indian chapter. Next slide. We have a population of 1.3 billion in India, and the CKD prevalence rate is 7,852 to 8,600 patients per million. Next slide. There are 6,500 patients of PD in India. Next slide. Over 130,000 patients receiving dialysis. The number is increasing by about 266 million, about 266 per million population. Next slide. With more than 1,800 nephrologists, there is a need to increase the knowledge and awareness about among the healthcare providers through various educational activities. And next slide. India's demand for dialysis was reported to be growing at a rate of 31%. So if you look into the picture, if you look into the national picture, you will find that the number of the end-stage renal diseases are coming up in a big way. So we have to provide an alternative to the hemodialysis. Next slide. If you look into the cost factor also, the monthly cost of 3 exchange peritoneal dialysis exchanged bags per day is almost similar to that of the one hemodialysis. So the monthly cost for a patient who is paying out of his pocket also, it's almost more or less similar. But when the government is providing free the consumables and the dialyzing fluid free through the Prime Minister's National Dialysis Program, this is going to be a much economical model for the state of Kerala. Next slide. And if you look into the HD proportional cost also, if you look into the HD claimants as a proportion of all claimants, you can see that there is an yearly increase of expenditure on hemodialysis as the percentage of total healthcare spend. This is a study which was done by Rajiv Arogyasri Community Health Insurance Scheme. Next slide. So if you look into Kerala, next slide. Kerala has a demographic for the population of 33.4 million. The ESRD prevalence is around 3,500 patients. The ESRD incidence is 140 per million population. That is one of the highest in India. And the principal etiology is that we have a high average of diabetes patients and hypertension patients in India. Kerala is considered to be the diabetic capital in India, with over 27% of the adult population being diabetic. It is said to be that 1 in 5 population in Kerala is having diabetes and 1 in 3 is having hypertension. So there is a high NCD burden which is leading to CKD and ESRD. And for the ESRD treatment, we have 940 dialysis machines exclusively under the Health Services Department, and the patients on hemodialysis is 3,959, and the patients on peritoneal dialysis is 404. So if you look at the numbers, peritoneal dialysis is much less compared to the hemodialysis. Next slide. So we started the COPD program in Kerala. I think Kerala was the first state in India, as Ratan sir has mentioned. We started the program in 2017-18 as a pilot project in 3 districts, in Palakkad, in Ernakulam, and in Trivandrum. In 2018-19, Kerala submitted a proposal in the PAP for funds under the PMNDP program for COPD. But at that time, Government of India declined to give the support, saying that COPD is not under their purview. So, but in 2019-20, COPD was included in PMNDP, so we started receiving funds through the Prime Minister's National Dialysis Program. So Kerala now has expanded the program from 3 districts to 14 districts, and all the medical colleges are supporting the project in all the districts. So we don't have nephrologists in all the district level hospitals. So wherever there is no nephrologist, the nephrologist or the nephrology team from the nearest medical college, they are doing the procedure, and they are sending the patients back for. So these are the number of patients who are receiving COPD patients from each district. Next slide. This is the proportion of COPD and the high hemodialysis. Next slide. So these are the number of renal transplant patients. So we have a steady number of renal transplant cases. So our aim is to reduce the number of transplant patients in the state. Next slide. Next slide. So next slide. This is the training plan that we have. We have a hub and spoke model. Next slide. So we have, previous one. We have 4 major centers, the Trivandrum GH, Palakkad DH, Kannur DH, and Ernakulam GH, which has got the nephrologists in position. They will be hand-holding the training in rest of the districts, and all the medical colleges are supporting the zonal training centers. So next slide. So if you look into the economics, health economics, you can see that there is a high expenditure for hemodialysis patients. Next slide. So the funding for dialysis comes from the central government revenue, from the social health insurance, from the external sources, the health financing, the out-of-pocket expenditure, the community-based insurance process, the voluntary private insurance. Next slide. The government funding comes from the CAS, the Karunya Arogya Suraksha Pathadi, which I think Dr. Vijay Ondol will be explaining more in the coming presentations. Next slide. The other projects are the KBF, the Karunya Benevolent Fund. Next slide. The NGOs, the Tanal, the Shanti Foundation, the Satya Sai Trust, some of the NGOs are also helping in dialysis program. Next slide. There are health insurance schemes under the ESI, the CGHS, the ECHS, the private insurance. Next slide. So this is the data that we got from the State Health Authority. We can see a steady increase in the dialysis claims. It is more high in government public hospitals, but you can see a steady trend of a rise in dialysis claims in the private sector also, even though there are more or less equal. Next slide. This is the monthly trend of peritoneal dialysis in the state. You can see that the government sector is faring much high in case of the peritoneal dialysis. You can see that the total number of peritoneal dialysis is almost equal to the government sector involvement. But regarding the peritoneal dialysis, the private sector is playing a very low profile role in the peritoneal dialysis sector. Next slide. And if we look into the monthly, this is the figure that is coming from February figures from the SHA. You can see that the daily average procedures, dialysis is much higher than that of other procedures. In January itself, the daily average procedure for dialysis is 2,600, whereas the other procedures altogether will come to around 1,744 only. Next slide. So this, which is the way forward. So we need to strengthen the NCD clinics. We need to strengthen the diabetic clinics. We need to strengthen the management of hypertension. We need to increase the control rates of diabetes and hypertension to shrink the reservoir of the end-stage renal diseases. We have to find the early detection of complications is very much necessary. So the detection for the complications, the detection by serum creatinine, urine albumin, etc., should start from the primary healthcare itself. There is a need for increased general awareness regarding the peritoneal dialysis and the end-stage renal diseases. That awareness should be for the general public as well as for the health personnel. So they should encourage the peritoneal dialysis program, especially the nephrologist group. And there should be a definite promotion of peritoneal dialysis, and we should bring down the kidney replacement therapy treatment. So we have to decrease the number of kidney replacements in the state. And also we have to do the augmenting of the financial options that are prevalent, so that the treatment for dialysis, the end-stage renal disease, become easy for every patient. Next slide. So that is it from the Kerala health side. Thank you very much.
Thank you, sir, for your comprehensive presentation. Next, we can understand the overview of Thailand's health system and the examples of implementation of peritoneal dialysis case. I would like to invite, with all respect, Dr. Somsak for having this presentation. Over to you, Dr. Somsak.
Thank you. It's my pleasure and honor to share experiences of Thailand with Kerala colleagues. For me, the fame of Kerala health system has been known to me since my early career in the mid-80s. And then I came to know much later that it was a result of very strong political commitment and leadership. So I'm very glad that we are now sharing some of the humble experiences from Thailand with Kerala, and also learn from you as we will discuss towards the end of this sharing. I will try to be spending about only 25 minutes of the 45-minute slot that we have agreed, because Dr. Yot and his team is also very crucial in making all this happen. But let me share with you the overall. Next one, please. Thailand, as you know, is the overall health system. As you know, it's a so-called upper middle income country now in Asia. But I'm very sure that we are not that proud on that in many fronts. But in health system, we could be quite proud in the sense it has been quite good in terms of return on investment. The total health expenditure now is about 4% of the GDP in 2017, and since we introduced the so-called UCS or Universal Health Coverage Scheme, we have been able to reverse the private-public spending, and the public spending is now about 76%. This is the overall three main schemes which covered almost 100% of the Thai population. The oldest scheme is the CSMBS, which is the civil servants, very restricted. Only about 9% of the total population benefited from this, and it is funded through a government budget, and the management system is not concerned much about strategic purchasing. It is just reimbursing hospital according to their rules, and their rules is very much fee-for-service based, which is very non-cost benefit or cost effective. And then in 1990, we have the so-called social security system. The social security system has a health component, which is the major part of the benefit package in the social security system. And as in many other countries, it is a tripartite system. It covers only about 15% of the total population because we don't have a very big formal sector. The informal sector has not yet been covered effectively by the social security system since its conception. And then in 2002, the political party that came into power introduced the UCS, Universal Coverage Scheme, to cover the rest of the population, and abandoning the previously scheme for free medical services for the poor. So it covers also the so-called non-poor, and the goal is to try to avoid catastrophic illness, because we know that when you become richer, the healthcare spending is very big, and you can bankrupt yourself if you are not properly taken care of. So one of the objectives of UCS policy, apart from equity in general, is to ensure the prevention of catastrophic health illnesses. And for this particular scheme, we have a law that set up a strategic purchasing body, which is called National Health Security Office, or NHSO. Next one, please. So far, we have been quite successful, as you know, but as I say, we still have a lot to improve on. But a few things that I think you should know about the so-called the background is the second point on this slide, which is that apart from the fact that we could reduce improve inequity and reduce the spending of the so-called low-income population in terms of health spending, the supply side has a very important factor to make sure that this scheme has been more or less implemented properly. Not to mention about evidence-based informed policy decision-making processes and the engagement of stakeholders such as NGOs and civil society in the overall governance of the system compared to other two schemes. But let me touch on the supply side, because I think Kerala and Thailand has more or less the same kind of historical development, although maybe Kerala has been here much longer, because as I say, I heard about that good health at low cost examples since the mid-80s, whereas Thailand has been more or less portrayed only around the year 2000. But the fact that primary healthcare and primary care system has been very much in the evolution of the Thai healthcare system has made it possible for the so-called supply side in Thailand to do that. And as you know, it's mostly the public sector. You show the responsibility or the work burden in the public sector more than the private sector when it comes to PD. For me, I always say that the public sector in Thailand has been very instrumental to make sure that the implementation of the UCS scheme came through, because they put all their efforts in trying to make sure that the policy has been properly implemented, despite many of the limitations and criticisms. Next one, please. And this is some of the results that you can look at it in more details in terms of the overall system. But basically, as I have shown in the earlier slides, the public sector has been very crucial, but the strategic purchasing body, NHSO, has also been very crucial. And the overall political atmosphere and the active participation with civil society has made the system, expanding in terms of capability and budget. We started with very low budget, and I'll tell you a bit about the peritoneal dialysis or the dialysis experiences later, because that has been one of the very first examples of whether the benefit package should include that or not. But in Thailand, basically, the benefit package is what I could call comprehensive health services as much as we have been able to provide it to the public sector before the scheme started, with a few exclusion list. And we try to manage that the payment system is cost benefit. Next one, please. Now go into the details about the renal dialysis system in Thailand. Again, you know, I have no need to mention that ESRD is a very important health challenge in terms of covering and providing good enough quality to the people. Not to mention that it is also a very costly services, and it is one of the important options that need to be considered when you have the benefit package for universal coverage. And I always like to tell the story that when the first minister who has to implement this policy came into the Ministry of Public Health, and she organized a meeting of the so-called high-level people and the technical people. One of the very first message to her is that, you know, despite the fact that the political party would like to claim that this policy treats all diseases, there are at least two important exceptions. The first one is ARV. The second one is dialysis. And she asked why. And of course, the explanation is very, very simple. It is very costly, and it extends life, and it will be even more costly in the future. And she couldn't understand why, you know, something which is very important in demand should be exempted. But of course, she complied, because that's what the technocrats advisors, and she is still not that daring to say, no, I will going to include that. But it's only a few years after that, you know, there are pressure from many other groups to include in the UHC program, especially after the introduction of the ARV. So the government tried to consider how to properly address this demand and this pressure. Next, please. So the so-called NHSO has to commission some kind of studies on how we could best address the ESRD, the end-stage renal diseases, whether it's need to be through transplantation or through dialysis or any other means, despite the fact that it has been known that it is a very challenging topic to try to consider in terms of benefit package, especially for the long-term implications. Next one. Luckily, you know, at that time, we have the mechanism in Thailand, which is the HPP and high-tech. The cost effectiveness analysis, cost analysis, economic analysis of beneficial or controversial intervention could be better addressed to some analysis. So the issue of should the Thai government include RRT in its benefit package of the UCS program has been picked up and assigned to do the need assessment, to do how the service readiness is like, and what kind of implications and what kind of population preferences would be like. And then they next one, please. And then they try to see how the so-called value for money for renal transplantation replacement therapy is, and what are the various what are the value money for dialysis modalities. And of course, finally, the debate was the consideration was whether we should do the PD first or the HD first. Next one. The result of the analysis is quite clear. You know, when the study was done, it was found that neither PD first nor HD first is cost benefit enough according to the Thai threshold value. It was about three times GDP per capita at that time. In other words, you know, if you are looking at whether we should include this benefit package or not, from economic analysis point of view, it is not cost benefit, and it should be so-called rejected. But of course, as I said, the societal response, the pressure from the public, and as well as the political leadership at that time, seems to indicate that the rejection of the services is not a choice. So you have to go and analyze and give the best advice as to if the ESRD patient is going to be so-called taken care of, what kind of benefit package should be considered. And of course, the analysis came to the conclusion that the PD first policy would be more cost effective and better, because it gives better coverage and it provides a much better so-called opportunities for those who are in need of services for many reasons that you have already known in your own context. Next one, please. But as I say, even though the policy decision take into consideration the economic analysis, finally the challenge is how do we design a system whereby PD first would be as effective as possible in covering the people's demand, given the fact that as you know, HD center has been price scarce. So they have to make sure that they design a so-called delivery system well. And one of the things that we did is that we deliver dialysis directly to patients' home. But as you say, the first encounter has to be at the so-called more or less specialized center, and then the regular supervision and visit at home of the people who receive or who do the peritoneal dialysis has to be done by the primary care people with supervision and consultation with the centers, the so-called the PD centers at the district level. So it's a combination of the secondary and tertiary center as well as the primary care level to take care of the people who are under peritoneal dialysis. But one of the advantages is that they don't have to travel just to receive the dialysis, because we have a system for the company to send it directly to patients' home. And this went in quite well because we set up the registration system as well, so that everybody can see who is under the so-called scheme. And of course, the fact that the primary care level has been informed and they have been taking active role, it also gives the patients better opportunity to consult directly or to call them directly in case of they have some problem. They don't have to go to the specialist or call the specialist all the time. Next one, please. And as you can predict, the peritoneal dialysis utilization increase exponentially, as you can see from this graph. Next one, please. But of course, these experiences has been shared with other countries, and at least 2 other countries that we have been working with, HITAC, Dr. Yot and his team in the international HIU team, has been working in Indonesia and the Philippines, which have more or less faced the same problem of doing the more hemodialysis and peritoneal dialysis. And the general experiences and the way that Thailand has been implementing the PD first policy has been shared with Indonesia and the Philippines. And let me go into some more detail. Dr. Yot and his team will give you more detail later. From Indonesia, it's the same. Geographical access to dialysis is very low. An estimate of 30% of patients, with 10 HD center, on 6,000 islands, Indonesia is a very unique situation. And the PD first policy was more cost effective according to the analysis compared to the HD first. Next one, please. And then they started with some 5 districts. I'm sure that they have been considering expanding or doing something more. And of course, they have to do training and they have to set up a service center to make sure that the backup system is there. In terms of the Philippines, next one, please. The Philippines has more or less the same. They have the HDF dominant form. 94% of the patients receive hemodialysis as compared to peritoneal dialysis. Maybe just like what happened in Kerala that you have just shared. But the important part of the Philippine system is that they provide only 90 sessions out of the needed 156 sessions. In other words, they only partially subsidize, partially paid for the demand or the needs. So it's up to the patients to decide how to do. They could pay for the rest, or they could just don't pay for the rest, but spacing their own services. which make the quality of the services very poor, and the return on investment is actually worse than paying for maybe for the whole 156 sessions. But anyway, next one, please. So the Philippines is also considering whether if they do the peritoneal dialysis, they could save costs as well as improving benefits. And we have distilled some lessons to share with much broader other countries on that. I'll come to the last part. Next one, please. Which is a challenge as an issue on going forward, because as I say, and as you have already alluded, it's not a simple policy decision that we have PD first and then that's all. Everything is solved, because the challenge is actually much more complicated than that. But let me address some of the direct implementation issues first, because as I said, the system design, including the linkage between the various levels, is still very much of a problem. In other words, even though you expect the primary care people to be the one who is consulted first, and they have regular visit, to ensure that there are proper practices, the dialysis is sent directly to their homes, and then if there are needs, they could consult the regional center or the district center, or even the tertiary care level. The system has not been functioning properly. It may have to do with the incentive systems. In the early phase of the implementation, NHSO provided some kind of financial incentive for primary care level people to do the so-called regular home visit, but that incentive was more or less discontinued. The centers are still there, and of course the people are still doing peritoneal dialysis with the possibility of being supervised and consulted the primary care level. And the primary care level does not only do home visit on peritoneal dialysis patient. Home visit has been one of the activities or services at the primary care level, so they could combine this into the other things, despite the so-called lack of incentive. In other words, they don't just need the financial incentive to make them do that. But again, this is something that is still a challenge. In terms of the competition, the hemodialysis business is also trying to expand to the district level. As you may know, the district hospital in Thailand has been very crucial. It provides both primary and secondary care. And many of the so-called more sophisticated services has been established there. So rather than just leaving the hemodialysis services in big cities, the business sector has been trying to make sure that the big district hospitals would also do that. And they provide all kinds of business models to make sure that outsourcing services is possible at the district level. And of course, it draws attention to the district hospital or the community hospitals from PD to HD. We don't have data as to how big that challenge is to the PD first policy. And of course, the quality of care provided has to be very much emphasized because of the criticisms and the skepticism of PD over HD. But it can be hardly maintained with the increased workload, because we have increasingly more and more people coming for services. In terms of budget, as you can see from this slide, Indonesia spent 4.1% of their total spending for UHC. Philippines is 7.7%, and in Thailand it's also 5.1%. In terms of the people covered, it is very, very few compared to the proportion of spending. So it is definitely a challenge. But of course, there's a need for innovation to treat the ESRD. But on the other hand, there has to be, as you say, emphasis on prevention. There have been a discussion about, properly paid for care for patients with DM and hypertension, as you mentioned, so that we could reduce the complication rate, and thus the so-called people who has to go into end-stage renal diseases. But how do you make sure that the payment system for these so-called NCDs, yield the lesser complication in terms of renal failure, so that you could save from the dialysis budget, and then put that into the DM and hypertension prevention, or even the secondary care, continuity of care is also a very big challenge. But another point that I think I like to leave it with you is that during the COVID pandemic, it was found that the patients who underwent HD has more difficulties continue their services because they have to be at the center, and the center has to have very good infection control measures, and some of them get infected when they went for HD, and they were afraid to go there. Whereas those under PD has been doing that in their home, in their family context. Supervision and consultation could be through teleconsultation and things like that. We are still doing some more detailed study on this to see how the so-called PD first policy has actually saved more lives, or even maintain a good quality of life despite the pandemic, because we think that would be also one of the very important message. So I'll stop there, because as I say, I would like Dr. Yot and his team, who has been working closely at the analysis phase in the beginning when the policy took place, as well as working with the nephrologist association, the renal specialist group, to design the system and to even communicate and enforce, and even to continue monitoring that, and to try to see what they can do, because I think one of the important part of this, the success so far of this policy, is the engagement and the commitment of the specialists in this particular aspect. In other words, they have not, although there are criticisms and skepticisms, the specialists has been engaged and so-called supportive of this PD first policy. Thank you very much, Dr. Yot and the team. You may like to add some of your comment. The next one is the last slide. Thank you. Okay, I'll stop there. And the team, please.
Thank you, sir, for your comprehensive presentation. And this floor is open for question answering. Some of the questions are already addressed by Dr. Biju, sir, from Sri Chitra. I would like to, could you please end the screen sharing? Yes, thank you. And this floor is purely for a question answering session. People can ask a question, and both the team will be ready to respond the questions.
First of all,
Yes,
Biju sir from Sridhar Institute, our technologies team.
Yeah, thank you. Thank you for this presentation. Actually, it was a great learning opportunity to me. I also look forward to hearing more on the comments and inputs from others. And with regard to the questions actually raised by you, actually, yeah, in here also clinicians are a bit apprehensive with regard to peritoneal dialysis, especially in Kerala. When we look at the rural areas, the aseptic precautions which should be taken in case of peritoneal dialysis when it is done at home, probably we have a bit compromised situation. So that could be one of the reason for a higher incidence of infections. I was wondering, like in Kerala, if we can provide peritoneal dialysis through our sub-centers, or with the help of the auxiliary health workers, or even at the primary health center, which is quite nearby to the patient. So when we are entrusting it to the patient to do at their home, quite a lot of poor folk would not have a very hygienic environment at their dwelling places. So if we can offer peritoneal dialysis in the sub-center, health sub-center, they can come and do that there, and that could be one option which we can think about. So I stop here.
May I add to Dr. Biju? I think it's a very good idea. I'm Jot, actually. I'm work under Dr. Somsat. And I'm part of the Ministry of Public Health. I think it's very good idea to think about, I mean, having alternative place for the patients to do peritoneal dialysis if they found that their home are not suitable. I think and yes, health center or sub centers, as you say, is nearby their home, can be a place to do that. I have a few more things to add on that one. I think 3 points. The first point, I think we need to do a better communication, even in Thailand. I talk is not about India. I don't know anything in Kerala, but I think what I learned from India, from Thailand, from Philippines and Indonesia, is that first is that the public and the patients misunderstood that PD is inferior service to hemodialysis, which is not true. Evidence worldwide already shows that in terms of quality of life, PD is superior compared to HD because the patients get dialysis done every day. So they are more stable in terms of toxics that are at low level all the time. So the quality of life in Thailand studies already 3 times, collecting hundreds of patients, showing the same thing that if adjusted by everything, comorbidity, etc., PD is a better quality of life compared to the HD patients. In terms of survival, is no significant, no difference. So it means that if done properly, patient will survive at the same length of time. So that is about, first is that we need to educate the public and the patient on this point. Second one, I saw from the chat box, I think that it can be very challenging if you allow clinicians to choose service for the patient on behalf of the patients, especially when I'm sorry to say that, but I'm a clinician too, to say that the if doctor have conflict of interest, they may prefer to offer the service that they can earn more. So in Thailand, it's the same. The doctor can charge doctor fee every time that patient visit them. So HD visits 3 times a week, but PD is visited once in 2 or 3 months. So it's very clear that doctor have direct financials in conflict of interest. If you ask them to choose dialysis for the patients, and that we need to find ways to direct practice. In Thailand, we do this. In 2008, when we decided to go for PD first policy. So the first newly diagnosed after January 2008, the patient who newly diagnosed as end-stage renal disease requiring dialysis, if they choose to go for PD, free, everything free, including erythropoietin. For hemodialysis, they need to pay for the full cost of hemodialysis themselves, but we offer them erythropoietin for free. Why we give them erythropoietin for free? Because we think this is something that is important. Second one is that we want to keep record of HD patient at the same time. So it's been a lot of financial burden to people to choose to go to HD unless they have contraindication to do PD, then they can go for HD for free too. Or they already use PD and they develop problem, they can no longer use PD, then they can go for HD for free for the rest of their life. So that is very strong message, very strong incentive. Regarding for doctors and nurses, at the beginning, we incentivize a lot. So we give like a 5 times, 6 times higher for doctor fee if they do, if they take care of PD patients. But in total, they will earn more from HD because the frequency of the visit. But this give a little bit of cheer up message for doctor who provide PD. At the moment, after more than 10 years, many doctors are become PD champion. Now, this year, at the beginning of this, just only the beginning of this last month, actually, the government decided that now no longer, after 10 more years, that we force patients to go for PD first. They provide free option, free choice. You can go for HD or PD. So previously you cannot. If you want to get it free, you go to PD only. But now you can choose between two choices. You know, I'm very surprised that doctors trying to cheer up the patient to go for PD. They believe that PD is better for patient. They said to me, I asked whether the patient who already on PD decided to come to HD because now they have free choice. They say no. Most of the patient, 90% who like or who already start PD, they decline to go back to HD. So it means this shows something that about the benefit, because once they on PD, they can work as a merchant, they can do even drive a taxi driver, etc. So that is more useful for them to sit, and a lot of travel costs because the HD center always in a big cities. And then the last one, as Dr. Somsak mentioned about, so I talked, the first one is about we need to educate the public. Let them think that PD is inferior compared to HD. Second one is we need some direction to direct clinician. We shouldn't give them free choice to choose on behalf of the patients. The third one is about system support. As Dr. Somsak mentioned, in Thailand we ask the postal service to deliver HD dialysis to patient home for free. And that is very helpful when we have a big fraud, when we have problem that patient they cannot travel, even COVID patients don't want to travel to hospital because COVID. So, but for PD it's opposite, everything deliver them at home. So I think the model that Dr. Biju mentioned about having sub-center at the place for PD can work well as well. If we can deliver dialysis to that sub-center and the patient just come themselves to that sub-centers, because if not, the cost of carrying dialysis is a lot. And after a few years, luckily that the company Baxter, I don't want to say, but it's the truth, is Baxter decided to relocate factories from Malaysia and on Philippines to Thailand. Now we have our locally made dialysis. So that is being foreign direct investment. That is a help economic of the country too, because I think in Southeast Asia we are the biggest market of renal dialysis in Southeast Asia. So I'm over to you. Thank you.
Biju sir, you have any comment?
No, I totally agree with actually it was true. Like in India, thanks to the HITAP team, Professor Samsung, Yot and Saudamani and all, actually in India also we have started with the health technology assessment in India, and as part of that we have now many regional resource centers, and ours is also one. And one of our center like PGA Chandigarh they have done this PDST question in India, and they also sounded the same. Like when we look at long-term effort, PD is of course better than SD. And of course the renal transplant in India, actually, although that is the permanent solution, we don't have much options to go for a renal transplant. And these are all what we have to do as of now. From the preventive side, actually, like in his presentation, Dr. Bipin Gopal has highlighted the need to address diabetes mellitus and hypertension and leptospirosis in Kerala. But I was wondering, in Thailand, do you have you started addressing this hyperinsulinemia actually like the dietary pattern should change. Actually, should we wait for the diabetes and hypertension to occur, or should we move ahead looking at hyperinsulinemia and that kind of have you started that kind of an approach in Thailand to address non-communicable diseases per se?
I don't know much about that one, but I'm sure that we are pushing for a better diabetes and hypertension control program in Thailand. There was a pilot study. I think actually is a cluster randomized control trial conducted in one province, Kamphaeng Phet, that they are. I think they published in Kidney International in 2008. No, sorry, in 2018. 17, 19, okay, and that showing that they use surrogate outcome, and then you look at GFR. They found that provide aggressive and early treatment for diabetes and hypertension can delay. They estimate allow 6 years of renal dialysis, so we can delay 6 years to do renal dialysis. And now they are in a process of conducting economic evaluation in order to put that program under universal care coverage. But diabetes screening, hypertension screening is free now in Thailand. But in that study, they provide early treatment, and they also talking about using genetics testing to identify, because there are some genetic abnormalities that you can identify patients with very high risk of develop nephrotic syndrome, and that is one of the major cause of early end-stage renal disease in Southeast Asian population. So they are mixing, and they're trying to do more on preventive sides of end-stage renal disease. But having said that, I don't think the problem in Thailand and in Kerala and in other countries in Southeast Asia of increasing end-stage renal disease, we cannot blame only NCD. But I think we are how to say, unfortunate because of our good work in health system. I believe that maybe Kerala people have one of the highest life expectancy in India. So that's why you observe a significant increase of end-stage renal disease. You look at Taiwan, you look at Japan, why they have such a high of end-stage renal disease incidence per population. Not for sure, not because of NCD alone, but because they live very long, and kidneys go first when compared to other organs to be failed. So that is sometimes I feel is some part is unavoidable, but for sure some part is avoidable, like diabetes, the treatment, and some genetic disease. I think that is something that we need to take care over.
Just like to add that, I heard that in Kerala, you are also trying to see how the primary care level could function much better in terms of NCD control. And then as we had discussing, as Dr. Yot pointed out, even though it may not be the total cost of renal failure, it could be quite a significant one that could be avoided. And as I say, the clinicians believe that if you have a good model of care, you could even avoid having renal complications, and you can die of other causes, even though you have diabetes and hypertension, without having to have renal failure as one of the consequences. And it's not only about early detection of complications, it's about better care to make sure that the vessels complication is not there. So I think that has been one of the challenges. The concept of value-based payment method has also been very much talked about, how you could create a much better linkage between the various levels as the family and self-care. I think that's something that maybe, as I say, Kerala has a very good primary care system as well. Could be a very good opportunity for further exchange and sharing. Thank you. Over to you.
Jaydev, you want to say something?
Grace.
Thank you. It's me who wants to ask a question, and it's related to something Dr. Bijou mentioned earlier, and we had discussed it with the Thailand team, and I'm going to put it to both of you, Dr. Bijou and Yot. Because for me, I'm looking at it from beyond Kerala, which has gone, because Kerala has high literacy rates compared to other states. Also, the public health system is quite good. So if we are thinking of a state like Bihar, maybe when we are thinking about PD at home, it might be a little bit of a stretch in terms of guaranteeing safety and infection prevention. So that, how can we have some sort of an indicative assessment that compares three approaches: PD at home, PD in the hospital, PD at sub-center level within the Ayushman Bharat framework from the health and wellness center's perspective, that can give us some guidance of what approach would be more cost effective within the India setting. Perhaps like some work done by both maybe Yot and Dr. Bijou. Is there some scope for that? Thank you.
I think very interesting, very interesting. To be honest, I haven't heard about having sub-center as a hub for doing dialysis in communities, and it's very interesting idea. I'm very supportive. So but I haven't seen any study. So India have potential to do this study to inform not only for India, and I think it will be also beneficial for other countries. I work on a few countries in Africa. They are facing the same problem of struggling how to do renal dialysis under universal care coverage. So I think the study is not going to be very difficult. It's not rocket science. For sure, I think the team in India can do. If they want to have some idea from our team, we are very happy to share our idea too. I think just trying to also collect the data from household perspective about indirect cost, traveling, and also the productivities when compare between people go to hemodialysis centers, how many days of work that they need to lost opportunity to earn. Compared to people who do dialysis at home or at sub-center, etc. I think if we do proper study, it will be very informative and it will be very useful to educate the public, empower them. Over.
Can I thank you, Yot and Grace for that interest. Actually, if we plan to do that in Bihar and other North Indian states, then probably we will not go down to the sub-centers. Actually, if we can create that some of the primary health centers or selected, as you said, this wellness centers, if we have a bed there, like an observation bed, and one of the auxiliary workers trained in conducting this PD, actually, which can be done by the local doctors, and so it can be done under their supervision. That way, we can cut down the cost of travel and all other things with regard to the hemodialysis. And peritoneal dialysis also can be the quality of that care of peritoneal dialysis patient can be improved. And if we can do that as a pilot somewhere, actually, I have one of my PhD students working on this. Actually, Dr. Anthony Stanley is working on it, but he explored, and we don't have a model anywhere. But this is a potential area. Actually, in Kerala also, if we are interested, we can pilot some, rather than implementing it everywhere. First, if we can pilot in some of the primary health centers or sub-centers with an observation bed and one or two staff trained specifically for this. That will be, as Yot was suggesting, and Dr. Samsak was suggesting, actually we can document the procedures, everything, and we can do a cost analysis of that. And that will be a good initiative for implementing that in India.
I think I'll add one of the important points that need to be emphasized for policymakers is that, once a policy like this, which is, not only controversial to begin with, but also have quite clear long-term system implication, both in terms of workload and budget. Once a policy like this is decided upon, it will be very important to have some kind of a monitoring mechanisms, not only to know what happened, but also to offer the opportunity to redesign how we do things. Because as Dr. Yot has described the Thai examples, what I call this the system design has to change maybe, or has to have different versions. So you don't have a fixed model. And if you find that there are certain things that need to be tweaked, you can certainly tweak in a more systematic way if you have a good monitoring system through some kind of a institution that know how to do system research as well. And as you mentioned, in case of Thailand, when you have the HTA team, and as far as I understand, Dr. Baram talked in the conference, in December, that the HTA unit is actually supposed to look at the system dimension as well. So you can combine the two dimensions, and this will be a very important, setup for such a policy decision. Because as we are discussing, in terms of India in general, the context will be different. But even within Kerala itself, there could be different kind of families, and different kind of families may need different kind of so-called alternative models, even for PD first. On the other hand, as Dr. Yot mentioned, if you could collect data from patient experiences point of view, the communication about the value of PD, and to demystify the fact that HD is better than PD would work much better, because you have now direct patient experiences information. So I mean, in order to implement such a difficult policy, I always see that the coordination or the work, the integration of the so-called research and monitoring, good monitoring system and research component to do system redesign, a very important part for the policy implementation in this particular aspect. Over to you.
Vipin sir, you want to say something?
Yeah, that's regarding what Dr. Biju Soman has already mentioned. The idea of starting peritoneal dialysis or maintaining the peritoneal dialysis at subcenters is a good idea, especially we are starting the health and wellness centers in the prior subcenter system, where a staff nurse is given in charge of the non-communicable diseases there. So she's a well-trained person, so she can very well look after the peritoneal dialysis at a subcenter level. But one thing that is what is against this is that we are promoting peritoneal dialysis in a way that we say that the patient can do the dialysis at home. And again, if we are institutionalizing the converting the center, the subcenter to be the place of provision, we are drifting again away from the home-based peritoneal care to, again, it's a institution-based peritoneal care. So that is something that we should address properly. I think Dr. Biju Soman can comment.
Can I actually, that's what Professor Somsak was stressing, like we should not have a one thing fit all kind of a proposition, like for patients who can afford to do that at home, who are confident enough, and the health staff, the clinician feel like they're confident enough to continue peritoneal dialysis at home, that can be offered. But if the patient prefer the subcenter, we should offer that services.
Sure.
That kind of a initiative you take, that will work.
Okay, that's a good idea. That's good.
Sir, you want to say something, Ratan sir? Or else Grace can.
Thank you, Latif. I think Sachin had asked a question in the chat, and I don't know whether it has been responded to.
I wonder how the specialists are, with PD and HD in Kerala. Are the specialists in Kerala more in favor of HD, and it would be very important and difficult to also work against them or to try to convince them to come for PD first, or are they very supportive of the PD policy, as Dr. Yot has elaborated the Thai case?
Yeah, in general, specialists favor SD due to many reasons, and of course the pressure of the pharmaceutical industry also is there and all. But there are doctors, there are nephrologists who are willing to explore this option, and they are looking for support. And some of the concerns is this increased infection rates in PD, and that is what deter many of the clinicians who are for PD to continue with that. So that's why I was thinking, like, if we can ensure the sterility precautions at the PD in domiciliary PD practices. In general, clinicians prefer ST due to so many reasons, and but the way they are trained, actually they are seeing it in tertiary care centers, and where ST is the no. And now they have to relearn to go. They should have that kind of a confidence to go for PD. And I really like your point, like one of the starting point would be to take a patient feedback. Now we have around 500 patients who are undergoing PD in Kerala, and if we can get their perspective and a sample of patients who are undergoing SD and their perception, and not only the patient but the caregiver's perception, then that could be a starting point, and we can feed that back into the clinicians.
One of the leading nephrologists in Kerala, Dr. Noble Gracious from Medical College Trivandrum, he actually commented yesterday that sending a patient for hemodialysis, he just need to write hemodialysis and the patient can be sent for hemodialysis. But if he wants to send a patient for a peritoneal dialysis, he need to spend at least 3 hours convincing the patient and the bystander that this is a procedure which is more effective than hemodialysis or even as simple as this. So that is one issue that the nephrologist actually has commented.
In Thai, sorry, I may add here. In Thailand, we provide we train nurses to be the one who are counseling patient and family member, relative caregiver, to decide it on this one. I think they have a certain way to train, and they have a certain protocol to approach patients, and it's quite effective. I think this is one of the things that if you think it might be useful, I can contact someone in Thailand to offer a seat for training for Indian nurses, something like that. I think that it can be helpful. Yeah. I think they provide many rounds of training, and now we have around 400 nurses trained on this one throughout the countries. And we found nurse can help a lot on this PD in supporting PD policy. They also they train not only on counseling, they train how to following up patient too. So they following up patient both at home and by phone. So they have a tools and questionnaire and materials to do this in a proper way. Over. And we found, in Thailand, we at the beginning we afraid the same thing when I remember when we discussed in 2007, 2008, when we are starting the policy, people would say Thai people cannot do this, they are poor hygiene, they are not very good in care themselves, self-care. But we proved, our peritonitis rate is comparable to the West. That I would say that. And this is, I think, maybe more than half is the PD nurse who are very good on this one. Over to you.
Dr. Sachin, you raised your hand. You have your question in the chat as well. Maybe you should ask your question from the chat.
Yeah, thank you very much, Dr. Somsak and Yot, for the comprehensive details about the PD program in Thailand. I just wanted to know, you mentioned that there is some capping for the number of dialysis under the insurance scheme. So how do you derive to that particular number of capping, and what is the experience of that particular intervention? Thank you.
I that the capping one, I was referring to the Philippines experiences to partially pay for the number of sessions that should be made available. That's the Philippine experiences. I don't think in Thailand we have any capping. But Dr. Yot, maybe you can elaborate on that, because he also asked about the other question on the role of the private sector. And as Kerala have pointed out, public sector shoulder most of the PD. Maybe the private sector are not that receptive. Yot, over to you.
I have nothing to add on capping, as Dr. Somsak rightly point out, only in the Philippines. And that is a very good lesson learned, that logically you think government pay part and then the patient will pay part and then everything will okay. But it is not true in real life. When the government pay only 90 sections, and then the household decided not to go for additional sections, and then you can see, I don't know, in that papers we show Thai patients on hemodialysis compared to the Philippine patient on hemodialysis. They died 2 times quicker. So in average, they only 2 years on dialysis. Compared with the age of 70, compared to Thai, they can live 5 to 7 years. So that is a pity because they are under treatment. Come back on the lower private sector. I think I can see one thing, not only private but also public too. In the past 10 years, we tried to limit the number of centers that can provide dialysis, not because of we want to be exclusive market, but because we learn from the West, especially in the US. You may heard a lot that the quality of dialysis in the US is very poor. A lot of patients die at dialysis centers, etc. So they are underperformed. They are very bad in terms of quality control. So that's why in Thailand they form the committees under the Royal College of Internal Medicine and Nephrologists Association. So every single center needs to be certified by them over 10 years. So you must have a very good quality, and you need to report certain things. And then they even measure the number of doctors per patient, nurse per patient to allow them to treat. And every single one register either on government or register to the renal dialysis registry. So it's very well controlled, I would say, but it can be a good thing also that in terms of quality. So that's why I say the quality is quite good, because they know everything if there's something wrong. For example, in the past 10 years, they have some cases like a lot of people become infected in hemodialysis centers, and they identify source of waters infected, not clean water problem. Then they suspend that center to do, and then they solve the problem, etc. So this is something that I think is quality control is need to be discussed too.
Very helpful. Thank you very much. And sorry for the confusion on Philippine part. Thank you.
Yeah, so in this case, private can pay a low, but they need to do a good quality. So you cannot just open a center with 2 hemodialysis machine and you have part-time nurse and part-time doctor to run. I don't think it's now possible in Thailand. Over to you.
I think one of the possible ideas about private sector is that if you are thinking about some kind of a PD center rather than PD at home, they could be convinced to set up such a unit as well. But as Dr. Yot mentioned, you have to have your standard guidelines and checklist to make sure that once they set up they also adhere to the needed quality, because that could be also another possibility for the private role in Kerala or in other parts of India. Thank you.
I want to second that. Actually, if Kerala can come up with a good training program for nurses or auxiliary workers to run these PD centers, and it can be offered to the private clinic, especially in rural areas, small private clinics and all, they will be interested. And there could be proper monitoring and supervision of those centers by the health system, and such a model can work.
I note one thing. PD and HD are very different systems, you know, in terms of capacity. HD centers, you need to count how many machines there, how many nurses, how many doctors there. So you need to talk about how many centers need to be available to provide service to a certain number of patients. That's for HD. But for PD, it's very different, you know. We found that one center in Thailand can provide a big ranges of service. Some centers provide only 100 care, only for 100 care, care for 100 of patients. But some center very big one, more than 1,000. So it depends on the capacity. These two centers, the number of staff is only double, but they provide 10 times higher service. So it depends. We have one autonomous hospital in Thailand that run 3 clinics and using the same team of clinician and nurse. So they are running in different provinces in Thailand too. So the PD is you have, especially now you do a lot of telemedicine. PD have a big potential to grow in terms of number of service provided per centers. Compared to HD, you have limited by the number of machines and hours run of the machines per day. Over to you.
I don't know how the Kerala experience is like in terms of home isolation and hospital services for COVID patients. But Dr. Yot's description reminded me of the comparability between what we call PD at home and PD at selected centers. You know, it could be comparable to how we handle the home isolation patients and patients in the hospitals for the COVID. My COVID patients, you know, as Dr. Yot mentioned, we have different business models, so you have to be so-called differentiate and try to provide the right incentive as well as the right supervision, as Dr. Bichu mentioned. So that would be one of the important and interesting experiences to compare to. Over to you.
Thank you all. Definitely, indeed, this platform definitely gives some insight, and that will be the way forward. I would like to, Jaydev, could you please have the closing remark from your end?
Yes. Thank you, Lateef, and thank you everyone for this very rich discussion. Firstly, I'd like to thank Dr. Kelkar for you to Dr. Kelkar for letting us know that this is something that would be useful for SHA and the government of Kerala, and we were very happy and privileged that Dr. Yot and Dr. Somsak took the time out to share their vast body of knowledge with us. So we're grateful for that, and also very grateful to Sodamani for helping out in coordinating and facilitating this from Thailand's end. Last but not the least, I would like to thank all of the participants here on this call today for being involved in this rich discussion, and we look forward to provide support in any way that we can and really help driving the agenda of universal health coverage in Kerala. So thank you again, everyone. Lateef, those are at least my final words. If there's something you would like to put on top, would be happy to hear from you. Over to you.
Yes, definitely. For an official vote of thanks, I would like to invite our Joint Director, Dr. Bijoy sir. He is the one who is always motivating us to organize these kind of programs. From my end, I would like to extend my sincere thanks to Dr. Biju, Somen sir, and Dr. Bibin and all the participants. I would like to invite Bijoy sir for official closing remark.
Thank you, Latif. As far as SHA State Health Agency is concerned, this was a very informative and discussion. And SHA, as explained by the Bibin sir in his earlier presentation, State Health Agency Kerala is implementing the two main government insurance schemes, health insurance schemes in Kerala, like Karunya Arogya Suraksha Paddhati and Karunya Benevolent Fund scheme. So actually what is happening is we have around 1,675 health benefit packages in our schemes. But actually what is happening is more than 60% of the claims, per day claims, is coming with hemodialysis. So what SHA Kerala is really thinks that Kerala in a position to think an alternative for this. It's a high time for a Kerala to think alternative for this. So I really feel that this discussion was very much helpful for us, and we will think of as your suggestions, and way forward also we may need your help for conducting the advocacy meetings because as Biju Soman sir said, this need a policy decision, because considering peritoneal dialysis as the primary modality, we may need some policy decisions, and sensitizing the doctors, physicians, nephrologists across the state, and for giving trainings to all concerned. So way forward also we may need your help. So I am expecting that support from you also. So for formality's sake, because we all are a team, so for formality's sake, for organizing such a meeting, I would like to express my sincere gratitude to the World Bank team, the Grace Kabania, Jaydev and Sachin for organizing this meeting, and at our Thailand team.
Dr. Vijay, WHO.
WHO team, sorry, WHO team. And then health intervention technology program team from the Thailand, Somsang and Yot and Sodamini. We express our sincere thanks to you all. Thank you for all participants. Bibin sir, Biju Soman sir, our executive director. Thank you all.
Please don't leave. If possible, could you please enable your camera? Then we will have a snap. It will definitely help us to document. Those who are comfortable to open the camera, please. Okay, thank you all. We can wind up here.
Thank you.
The pleasure is all mine.
Thank you.
Thank you.
Thank you.
Thank you.